to 170, 180, so you've got some tachycardia, and you've got some variability there, maybe even moderate, but your decels are abrupt, so those are variables, and they call the physician and diagnose her with uterine dehiscence. So where they went after that, they probably went back to the OR, and the baby's APGARs were 8 and 9. And here's another trial of labor after C-section. She is a G4P3, induction for 3 days with oxytocin as high as 26 milliunits per minute. So you know that's cranking. That is a lot. And in places that actually do attempt TOLACs or VBACs, and we do not, oftentimes those patients have to go into labor on their own. They won't run PIT or do any type of cervical ripening, cervical agents. So she's had an induction for 3 days and her PIT was super high. She's had non-reassuring fetal heart tones for 4 hours and no OB provider is in the house. So you can think what you want about that, but really, is that a good place for a VBAC? Probably not. So the baby's had some bradycardia for 20 minutes prior to birth. So they probably had to try to get someone in-house to do an emergency C-section. And that's not what you want to see. Huge bradycardic episode and just barely anything at the very end there. This baby's heart rate was less than 60, and they didn't intervene with a C-section. They put on the forceps and delivered a 7-pound, 14-ounce baby with APGARs 1, 1, and 3 with a pH of 6.63. So that's just not what you want to see. And I guess the takeaway from this is just that's why you have a healthy respect for TOLAC or VBAC and what you need to have in place in your facility about how you deal with emergencies like that. All right, this is a G3P2. She had a vag delivery and then she had a C-section. She's 39 and 2 and came in spontaneous labor. She's 7, 0 station. They are augmenting her with some oxytocin. Maximum dose was 6. And then she got an epidural and they placed a fetal scalp electrode and an IUPC. And there is your tracing right there. So right now, I'm hoping that you're thinking that you've got some variables there. You need to be doing some interventions, turning her and moving her. If you got variables, you're thinking cord. You might not necessarily be thinking bleeding, but it's getting a little bit more minimal variability, and it almost has an undulating pattern to it, even though it's not real textbook. All right, 30 minutes later, it's getting a little flatter. Variables are getting a little deeper. So the physician orders an amnio infusion, which is fairly, that's appropriate. They're having variables, and so you want to you're thinking cord, and you want to get some fluid in there to give some padding to that cord. But then it continues, and you have what looked like was trying to be a prolonged deceleration, but it did come back up. And then you do have another deceleration right at the contraction there. And they're getting a large amount of fluid out. They must have had some problems with the IUPC, because then they put the TOCO back on. And I guess I would want to get my 2 cents in here. if you have a toco in for amnio infusion and it seems like it's not working properly and you're still using it for amnio infusion, and then you think you should just apply the toco because it doesn't seem to be working, I would suggest that you ask the provider to replace it and try to work that way, because you need to try to make sure that you're able to keep track of the intrauterine pressure if you're going to do amnio infusion, not just leave it in and continue your infusion and then do external monitoring. You could get caught that way, that you might have something going on you couldn't tell. So then she has another prolonged deceleration. They turn off her pit and they give her an IV bolus and they decide to do a C-section. Decision to incision is 9 minutes. That's great, but on APGAR's 4 and 8, so good resuscitation. It was a complete uterine rupture and they repaired it and they had a good outcome with mom and baby. So I think that they acted appropriately, and even when you do act appropriately, sometimes your baby doesn't have the reserve that you think the baby might have, and this baby probably did, and that was fortunate. So they had a good outcome. So it's not always just about how you do. It's what your baby's got left, how much reserve that baby's got, and you can't always tell. Second stage labor, which is pushing, requires evaluation also. You need to evaluate your fetal heart tones every 5 minutes without risk factors and every 15 minutes without. So every 5 minutes with risk factors, and if they're on PIT, that means they have their risk factor. And you also evaluate if you need to do intrauterine resuscitation and evaluation of fetal descent. So in charting also, I'll get my 2 cents in here. As you're pushing, as your patient's pushing, you need to document that, how that pushing is going. Is it effective? Are they being coached? Are they making a little bit of progress? Things like that. And so that's important, because if you push for 2.5 hours and your outcome is less than great, or your outcome's okay but your baby maybe needs a little resuscitation, it's good to have in the chart that you kept pushing for that length of time because you were making progress, and that was, you're making some good progress. So I would just remind everyone of that. Okay, and we talked about this in the last review, modified maternal pushing. And she's pushing 1 contraction out of 3. But to me, it doesn't look like that, because it has that picket fence look at the bottom there. But maybe what they're saying is she's pushing 1 time instead of 3 long times. But even that doesn't look like that at the bottom. But that's okay. So they're just saying that you should attempt some modified maternal pushing. You got some deep, persistent variables there. Or I should say deep recurrent variables there, so you want to do some modified pushing with that. And here as an illustration, I don't know if this is the same patient or another patient, where this patient is pushing every other contraction. So you can see the smooth waveform on the bottom where she's not pushing. The middle contraction, you got that little bit of picket fence look to it, and then the third one there, it's smooth where she's not pushing. And they put the vacuum on in APGAR of 6 and 9, which good, shows you some good results there. Here's another case, second stage labor. She's a G2P1, 40 and 3. Reg exam shows that she's 8 to 9, 100% -1 with a bulging bag of water. And that baby looks pretty good. I would be happy with that. You got some moderate variability there. So a category 1. All right, a little bit further along there. Doesn't look too bad. Still have some moderate variability, and you don't have any tachycardia or anything. Maybe a few contractions on the bottom there. Nothing too anything to get too nervous about. She gets up to the bathroom and the physician's notified. It doesn't say what he or she is notified about. She comes back from the bathroom. Still looks all right. Contraction pattern looks normal. There's not any tachysystole or anything going on there. And she's emptied her bladder before she got up, and then they're placing an epidural. So now you've got a little bit less variability, and again it shows you the progression of the strip. It's probably some minimal variability there. She gets the epidural. And she must have been, oh yeah, she's complete. And they decided because she's comfortable, she's going to labor down. So she's going to just wait until she feels the urge to push and recheck in 1 hour, which is great charting because it just tells what the plan is. And that's always a good idea to do that. Recheck in 1 hour and chart that in there. But then, holy cow, what happens? Then her water breaks, and we saw this strip on the last group of slides. And it's clear, but then all of a sudden you have what is hard to tell is going on really there. Some little pieces of fetal heart tones, probably a deceleration, and then a little further in the strip there, it looks like heart rate is down to 60. So again, we talked about this before. With interventions, you're going to really just do all of your interventions. You really don't know what's going on, so you're going to change position. You're going to decrease or turn off, well, you're going to turn off your PIT. If there's PIT going, you're going to do your fluid bolus and your O2, and if it's looking like that, I mean, you're preparing for to facilitate a delivery. So then a little bit as they do their interventions, it comes back up, but seems like it probably took a million years because you're by the bedside there waiting and waiting, and then the physician comes in and it's up for a little bit, but then it looks like it wants to go back down. And so with rest, the baby looks like it's improved a bit. And then it's hard to tell what's going on the bottom. And really for the test, if you see something like this, the right answer is, can you really tell how often she's contracting? No, you can't. So you're always going to palpate. You're going to, troubleshoot your monitor, reposition, all of those things, and then maybe they're going to ask, you're going to ask for IUPC. But if they want to know what your contraction pattern is, you can't really say. You can't say what's going on. And I remember there being that option of not enough information to say, and that's true. You wouldn't be able to say too much from that strip about contractions. So now it goes to, minimal to not really absent it's probably almost absent variability. She's got an IUPC in, but she's laboring down and charting that the plan is to check in 30 minutes. Physician's at the bedside in his 30 minutes or her 30 minutes. And now it's 7 o'clock in the morning. They got some, contractions look pretty good. It's not got a lot of break in between, but then at the end you have some there where there's a good break, so it's probably not tachysystole if you were to count up to see if you had 3 in your 10 minutes. Probably not, because that seems about right. And now it's time to begin pushing. She had labor down for 2 hours. And you have some moderate variability. You have some, what looks like pretty average uterine activity. And doesn't look too bad overall. She's pushing, and then at the end, holy cow, this baby just says, I give up, and has a huge deceleration. So what are your interventions? It's going to be basically the same. You're going to do all of your interventions. You don't really know what's going on. It could be a cord. It could be because it's a prolonged deceleration. You might have had some sort of abruption or event. So you're going to think about doing all your interventions all at once and maybe an operative delivery unless you can get it to come back up. And that, and now we leave you without telling you what happened. There was a 20% abruption, and she delivered by forceps, and the baby had a good outcome. Now this is something that you should commit to memory. Nice little table, and that's provided in those handouts that I'll send out to you all. Narcotics, as you, I'm sure, have seen in practice, decrease your variability and decrease your accelerations. Fetal can cause that transient sinusoidal, or what we used to call pseudo-sinusoidal. If you use Nubane, that can do the same thing, and that's not listed here. Cocaine can decrease your variability. Mag sulfate does decrease your variability also. You get a really flattened looking strip, and sometimes you don't get accelerations that are, say, 15 by 15 if you have a near-term baby. They're a little bit smaller. Betamethasone can decrease your variability, and you might see that if you work in triage on occasion and someone comes in for their betamethasone and then they come in for the next dose and you have them on the monitor, you might see some decreased variability. I remember there being at least 2 questions on the test about this. I think magnesium and betamethasone, and so you guys will have to let me know if those are the same. Terbutaline causes an increase baseline, and zidovudine, I don't even know if that's right, because we don't see that used that much. It's HIV medication. There's no change in fetal heart rate baseline. And I guess they include that because maybe that was on the test one time. So just file that away in your little brains. Okay, here's an example question. We didn't talk about lambda, and for the test I don't think you need to know it. Lambda is that pattern that, and I'll kind of like draw it here, where it goes up and then goes down like that. It's like kind of like a sideways S. That's a lambda. We didn't talk about that, and I don't think you need to know that. But the fetal heart rate pattern likely to develop with severe fetal anemia is the saltatory is that marked variability, so we know that's not right, and sinusoidal is the right answer there. See. Okay, a strip to look at. There were twin questions on the test, and so when you have these, just go through step by step, just like you do with the other ones. With single gestation pregnancies, do one strip at a time, and they should be labeled. If they're not, well, they'll be labeled, or they won't have it on there. Twin A is the darker one, and twin B is the lighter one. So with twin A being the darker one, you have to go through and just see if there's tachycardia or bradycardia. And I'll tell you, just because you can't see, it's a normal heart rate. I mean, it's a normal baseline, but the variability is minimal. And then twin B, which is The lighter one, that baby has a normal baseline and and has moderate variability.